Okay, make it all my actual thing down. Make it all my actual thing. Oh yeah, that works.
I'll stop at the presidents. Yeah. It's central. Wait, what about next year? That's good. Yeah, I like New Zealand policies. Driving over it's actually not that bad. Like when I know Google Maps, it's not that bad. Like 40 minute drive, peak hour, and the whole thing's an N3, so yeah, hopefully it takes me an hour to get there max. At least you would have been good for me. Because obviously you're not so close. Yeah. Alright, at least if I go there, there'll be like not that many people, so it's like chill. Hopefully the things do get better. Not chill. YTV. Oh yeah, the boys. Oh, look at this. It's like anxiety. Like there's no one here, just me and me, the boys, and he's like YTV. I wouldn't say that.
Just thinking. Do you reckon more people will come?
I don't know.
Hard to say.
Ask a few people. I haven't been to regional lecture in a while. So.
Yeah.
Like the last time I went to was gastro, so you can imagine the whole universe.
Oh, dude. Yeah, fair enough.
Yeah.
It's approaching the end of the year. Do you reckon we should just start?
Yeah, sure.
Yeah.
I'm very happy that it's stress test.
Sounds good. And we can pretty much just do, like, you can tell me to hurry through things if you want to. You can tell me to hurry through things if you want to, or like
Thank you.
tailor it to what you actually.
That'll be good. Saves our time as well. And
Yeah.
I think we'll learn better with fewer people.
Yeah.
That'll be nice.
Okay, you're free to go. Am I free to use?
Yeah, go use it. Just sorry,
That's fine. You just come up.
Yeah, I'm horrible at it. That's why. Like I did really bad in the exam. Like I got 2 out of 7 for ID, so I figured out.
Cool.
Yeah.
Ooh.
You got 0. Ow, you could have just guessed. Yeah, it got more than.
Okay, so it'll just be like ID and derm, and yeah, as I said, whatever you guys actually want. That's your matrix. At least it was ours last year, and hopefully we'll cover most of it in the slides. So yeah, that's what I thought were good sources for all your like gastro, like travelers diarrhea and stuff. I think CDC is really helpful. It has really good summaries. And if you're trying to the Centre for Disease Control. Yeah, so I would recommend using that for like trying to distinguish between them. Yeah, and then so again with this stuff, if you want to like go through it, skip through it, just let me know as well.
Yeah.
Which I think you'd probably know this already. So we'll skip that. The thing to know with like bacterial staining is it still comes up, so you definitely still know which ones are which with it, and know which ones are cocci and bacilli as well. So in terms of remembering what's positive and negative, the easiest way is just to be like all the cocci, sort of your staph, your strep, and your enterococci are all gram-positive. And then basically most other things, if you're going to take a guess, most of them will be gram-negative. So if you have to sort of guess, if they're not one of them, they're gram-negative, apart from like C. difficile and Listeria. They're pretty much the only other ones. Then that's like, I find that useful to go back to when I'm trying to understand things, because they all come up so often, especially probably like this year, like group A strep and group B strep sort of, they get like thrown around a lot anyway in year 4. So, and then in terms of your gram-negative, I think the 2 most important to actually know about how they look when you actually stain them are E. coli, which is a bacilli, and then Neisseria, which is a diplococci. And then just to remember that, I just like, because Neisseria meningitis is obviously associated with meningitis, it's like sends you dippy. So then if you like are trying to work out, because it does come up, I think, they can like ask you about gram-negative diplococci. Your hospital-acquired infections are pretty straightforward. Your MRSA is like obviously the main one. You need to know to treat that with vancomycin. VRE is the other one, so vancomycin-resistant enterococci. I don't think treating that is as important, but useful to know what it actually is. And ESBL is the other one. And obviously, sort of, if you start thinking about hospital-acquired infections, if they are an inpatient, different sources say different like lengths of time. Some say 24 hours, some say like they need to have been an inpatient for 48 hours, but you know, they have to have been an inpatient for a little bit and they shouldn't have had a fever before. So if they had a fever like as they were coming in, it's probably not hospital-acquired. Or if they've recently been at hospital as well. Antibiotics, I'm not going through this really because Joel, I think, is doing one next week on antibiotics. And Joel has some really good memory tools, so it'd actually be probably useful to go to. But I kept some of these slides in just as
Why is it happening next week?
I think, I don't know, yeah.
Oh, another idea then next week.
Yeah, just for antibiotics, so yeah. And yeah, so that's just like a summary, but I won't go through it because he'll go through all of it. But yeah, he's got good memory devices. And then in terms of OSCEs for infectious diseases, like, yeah, so you've got your basic history thing. The thing with ID, which I actually think is really great, but it can affect anything. So if you're taking a sort of fever history, you got to think about like everywhere in the body, obviously. But I think it's always good to start with your systemic symptoms first with ID and then go localized. And then in terms of systems review, I'm assuming you guys have heard of chick toads. Yeah. And I just added in, I think I added in, I got it from someone, like at the start to just remember to do, yeah, food, immunizations and tattoos as well. And I also don't know where there's like for travel history, you can use travel as a mnemonic as well. So just like time, meaning sort of the dates and duration of the travel route, sort of where you've actually been. And especially like sort of distinguishing between rural and city because it's different types of things. A being accommodation and activities, B being your vaccinations, and sort of that's also referring to other prophylaxis, so like malaria prophylaxis and things like that, even though that's obviously not a vaccine. And then exposures being sick contacts or contacts with sort of animals, etc. Stuff like that. And L just being, you can look at for location-specific outbreaks, which is pretty much just to use up the L. Yeah, and then an ID exam is there. Basically, it's going through everything. So
I think
no, that we had in ours that they gave us a post-op fever as
that
our.
one makes sense because that one's just like wind, water,
Yeah.
and all that.
Yeah.
I don't think I've seen it before.
You probably wouldn't, but yeah, you probably. I doubt you would get it. I doubt you would get it, but
Yeah.
it's there if you want to.
Sorry,
Yes.
did I say before that?
I think the slides will.
Oh.
The slides go up. I think.
Okay.
Yeah, so that's fine. And then septic screen. I've never actually worked out, like, found a good source as what exactly consists of a septic screen. But I think the three like most important ones to remember are your urinalysis, FB, blood cultures. Then the rest of these things are also important. So like swabbing, if it's relevant, ESR or CRP, your LDH, serologies obviously, and PCRs depending on what you're doing. And then chest X, so imaging stuff, and then LP if there's any suggestion of meningitis. This is the sort of like ID-specific OSCE topics that I think could come up. There's obviously ID comes up in other things though, so I haven't counted stuff like viral hepatitis. That's okay.
You can book in here. Or?
Yeah, we're good at that.
Yeah, and stuff like that, and other things come up in different systems. So post-op fever. Well, so yeah, you know them. So what are the things you look for?
So wind for atelectasis.
Yeah.
For UTI.
Mhm.
Is walking third? I don't know, but what wind, water, walking for PE. Why walking there? Because you walk and then you just collapse.
You're not walking, I guess.
Wind, water,
So.
walking. Wonder drugs.
Yeah.
That was one more.
I think they're the 5. I think I've only got 5, but there could be another one. I don't know.
I think I mentioned 4 or 5.
Oh,
I don't know.
did I make up that you mentioned 5? I don't know. I thought I heard 5. So that's how.
Wound. Sorry, that's what I forgot. Wound.
Oh, I thought you said wound. Okay, that's how I've got it. But different sources will say different things as well. So.
Yeah, it's really confusing because I remember learning from the 5th year, and the 5th year told me this order, and then there's a lecturer. Sorry, not lecturer. The surgical registrar gave us a tube, and then he gave us walking as a third one. So
yeah.
we're all a bit confused.
So like, because DVT, sort of, this is the other way I learnt it, because this is more like, DVT can kind of appear anywhere, but it's like the classic way we were taught it was sort of as the after 7 days, but you can get a DVT earlier as well.
Is it important to remember the exact time, so like less than 48 hours, 35 days, or is it?
I wouldn't like commit them to like exact memory, but it's good to have a sort of idea. If someone's just had their surgery, what are you worried about the most? If they're like a week out of their surgery, what are you more worried about? Then you're thinking DVT. So it's like rough. Don't like know exactly because it's not exact. It's just more rough, like.
So can we go back one slide?
Yeah, sure.
So DVT. Oh, no, that makes sense. Thank you.
Yeah. Yeah. So, and then pyrexia of unknown origin. So that's the actual definition of it is like over 3 weeks duration. You have to have had a fever on several occasions. So it doesn't have to be continuous, but like multiple times during those three weeks. And after appropriate investigation, you don't have a diagnosis, and that classifies as that. Can you think of what would be your main differentials in those sort of situations? Yeah. If it's after 3 weeks and like even though you've done like all these tests, what might you think? Could be.
Like if they travel, I mean, what do they?
Yeah, it could be TB.
I could think about brain, it could be meningitis, I could think about it could also be PE.
Yeah.
It could be a lot of things. It could be wound infections. It could be gastro-GI infections.
Yeah, so that's pretty much like what I do. Is it's like could be anything. Yeah. The one to really think about with this is drugs, because like it doesn't come up when you're like most of your investigation. So like a chest X-ray should show pneumonia. If you do an LP, you should be able to find meningitis. If they have malaria and it's actually proper malaria, they should be pretty sick. And you normally do thick and thin films if you've got any suspicion, and that should hopefully show it. So drugs is like the one you really want to think about, but it can be any sort of infection. TB is a good one, like it could be TB. And then your inflammatory sort of autoimmune conditions and malignancy, sort of hematological things is another one to think about. And then there's some investigations and more investigations. I don't know how high yield it is, so, but it's there. Yeah, I don't think so. Yeah, so fever in a return to, okay, this one, do you guys have differentials for this?
Yeah, number one would be malaria.
Yes.
And then like other things you consider is like dengue, TB. If they've got diarrhea, then you have to travel with diarrhea as well. If they've got meningitis,
yeah.
What was the other one?
Dengue.
That was like one more. That was relatively important.
Yeah.
Sorry, I can't remember. Yeah, I just
You
remember
could
malaria, dengue, and...
Are you thinking like yellow fever or something like that? Or Japanese? Like, I don't know. I don't know if they've come up as much. Like, I don't actually...
I wasn't thinking yellow
No.
fever. I was thinking,
These are my ones.
oh, typhoid.
Typhoid, okay. Yeah. So, yeah, that's my way of remembering it. It's like obviously more ones as well. The important one to always consider is like influenza or something like that, because I'm pretty sure I was taught at some point that was like the most common thing to come back with. Also like DVT, because they've often had like long travel stuff. So malaria is always the top, and you always got to rule it out. So that's the first thing you think of. That's good. Dengue is another really important one. Measles, it's kind of more not as important, but you can get regional outbreaks. Dysentery, so for your bloody diarrhea, which salmonella can also give that. It's not as classically travel associated though, but it obviously you can get it traveling as well. So typhoid as well. some buzzwords. I like remember the rose spots for typhoid literally just being like from Typhoid Mary. And there's like that nursery rhyme about Mary, Mary, quite contrary. How does the garden grow? And so I just think of roses. And hepatitis is another one. Hepatitis is something that comes up as well as a travel issue. And gastro, obviously. And UTIs as well is another one. And also STIs. So it's always good to ask about if they've had unprotected sex. So that's also STIs plus sort of like Hep B as well.
So when you're talking about your differentials at the end of the history, if they've had sexual intercourse when they're overseas, you just go like, they have an STI, or do you have to be specific? So like, you could just say like, oh, they could have syphilis, like, you don't really, I don't really, you know.
I think at third year you can just say STI, but if you want to be safe, definitely just, and you have them on the top of your head, just say it.
Yeah.
Just, you're not, there's no harm in just saying more. Yeah. If you want to. An infectious diarrhea, there's actually so many.
This one's hard.
Yeah.
Well, that is the most common was traveler's.
Yes, so traveler's diarrhea, that is E. coli, as you're right. You're right about that. You can also get other types of E. coli, which are like the sugar-like toxin. So if you ever hear your sugar-like toxin, it like can give you HUS, which is your like hemolytic uremic syndrome. So salmonella is classically chicken, bloody diarrhea, and this sort of, as we're saying, it's typhoid. So salmonella typhi, and it's tends to have an incubation period of 12 to 24 hours. And these actually, in some questions, like it actually is necessary to sort of know what the incubation period is. Yeah. Okay, Campylobacter is mainly carried by like poultry. So it's either sort of in cooked poultry or like in water, which has had lots of around it. And it can give you bloody diarrhea as well, and it has an incubation period of 2 to 5 days. Shigella, the most important sort of thing to remember about that is the tenesmus, because it doesn't really happen with any other of the infectious diarrheas. So if they say that, then you can just straight away think of Shigella. C. difficile, I think we probably already know, is like antibiotic related, and it's good to know that you treat it with metronidazole as well. Staph aureus is another foodborne one, and the thing with this one is it's a preformed toxin. So basically that means the toxin's like, because it's preformed, it means you get a like immediate reaction. So it's the one that presents most acutely. So you like might be like 30 minutes after they've eaten, or tends to be within like 6 hours. Like, so that's like the acute food poisoning. And you get sudden onset vomiting and abdo pain. Not as much diarrhea associated with stuff. B. cereus is rice, which I think everyone knows as well. Again, fairly acute. Cholera is rice water stools. Your viral causes tend to be like children. So if you have kindergarten teachers or just parents who have kids or kids, it tends to be viral. So norovirus is the most common, and rotavirus is less common, but it's more severe. So
is it norovirus in adults and rotavirus in children?
Might be. Is that what you've learned? I don't know.
I think
it could be. That could be accurate. Yeah. Parasitic ones as well. So you've got Giardia, and then amoeba, and Cryptosporidium. Cryptosporidium is usually not that important unless they're immunocompromised. And it's like associated with cattle. To distinguish between Giardia and Nantamoeba, so an Nantamoeba tends to be bloody, whereas Giardia doesn't. So if you're sort of tossing up between the two of them, because they'll usually give you an indication that it's like parasitic. If it, like they'll say it has the trozocytes or cysts or something like that. And they can also, Giardia can become chronic. So if someone gets chronic diarrhea after travel, it's probably Giardia as well.
What's OCP?
Oversystem parasites.
Oh, it's not.
No, sorry.
Yeah.
Sorry, I just didn't
That
have.
was a good question. I didn't even
I didn't have time
Good question,
to.
actually.
There's not enough room to like write it.
So what was it?
Oversystem parasites. So like if you're saying stool culture, so you also say, because culture is like you're looking sort of more for bacterial things.
Yeah.
Over-system parasites is like saying you're like thinking about parasites as a cause. So if you like have a infectious diarrhea case, OSCE or whatever, it's good to say culture plus OCP. Yeah, to like show you've been thinking about parasites as a cause. Okay. And again, so I've only gone through the conditions which are like on the matrix under ID, but obviously there's a lot of other things which are ID, but hopefully they were done by other revision lectures. Well, yeah.
Yeah, like meningitis and stuff.
Yeah. And hepatitis.
Systems based.
Yes. Yeah. So sepsis is essentially bacteria so bacteremia, plus you have to have an inflammatory response. So that's essentially a fever. So you have a bacteremia plus a fever is essentially what sepsis is. You probably know most of this, I would say. CRP, like really high CRPs is something to indicate it over just like sort of a localized infection. And like remember to give IV fluids and do blood cultures and then start broad spectrum antibiotics straight away, essentially. The two sort of big types are your staph bacteremia and your meningococcal as well. In terms of what's important, staph, the one thing with that is you just assume that they have IE until, infective endocarditis until it's proven otherwise. So you sort of have to do an echo straight away with those ones. So that's the sort of like main thing to remember about it. The other thing is it can come sort of from, you can get sort of osteomyelitis, intra-abdominal infections, and if they have a foreign body, so say if they have like a hip replacement or something, it's at risk of becoming infected if they have a staph bacteremia. Meningococcal, the main thing is like it's usually associated with it's often at this level sort of associated with meningitis as well. So you have a meningococcal sort of sepsis. So you get the systemic features of the rash, which is just sort of tends to be purpuric maculopapular purpuric mainly. But it can really look like anything from what I've been told. But yeah, and it can kill young people. So it's important, and that's one of the ways the rash can look. But I guess if you're sort of thinking someone who's septic with a rash, it's usually probably meningococcal. Or if they have signs of meningitis and a rash as well. Okay, so HIV. So essentially, it's a retrovirus. So it's a virus, which is in the name. And it targets your CD4 T helper cells and can also go into dendrites and macrophages, which basically is why you get the immune response. I'm sure you probably know that as well. And so it's transmitted by blood and bodily fluid. So the actual maternal to fetal, so that's like during pregnancy, during birth, or in breastfeeding, that's the highest chances of transmission. So it's in terms of, how likely it is to be transmitted. The next after that is sexual transmission with men to men being the highest chance of it. And then obviously other forms of sexual transmission are also possible. Then you've also got your blood transfusions, tattoos, and if they use IV drugs. I think you probably know the risk factors. Also, one thing is if they have a past history of STIs, essentially it's like if you've had one STI, you're more at risk of any other STI. So that's one. It's good to know that the window period is 6 weeks because it comes into testing. And I think HIV testing can come up as well on OSCEs. So it's good to know a little bit about it. So your two sort of ones, so you have your sort of screening test when you first, which is your ELISA tests. So it's sensitive, so it picks up most people essentially if they have it, but it's not specific, so you might get false positives. So there's two types. There's rapid, which is just like a skin prick thing, and it takes 10 to 20 minutes to get the results, but it's not as accurate, and it's sort of the post-exposure time where it's not very good at picking things up is 12 weeks. Whereas if you do the conventional screening, which is like a blood test, it's more likely to be accurate, less likely to have false positives, but it takes days to come back. So, and then the Western blot is what you do after. So if you've done your ELISA, it comes back positive, then you do a Western blot. So it's a diagnostic test.
Do you know much about those tests? Because I've heard that there are especially situations in which we need to explain, for example, to HIV people why they are like,
obviously, I don't know what can come, but that's what I heard when I was in your year.
Yeah.
I heard that they can come up.
Yeah.
So it didn't come up for us, but I mean, that means it's probably, So I think it is worthwhile knowing. Yeah. Then this is just like a graph of the like natural history. So it's on the next slide, but we can go back to it. So essentially you've got your seroconversion phase. So that was let's just talk to this. So you've got acute infection or the seroconversion phase. So that tends to just come up as like a flu-like illness. And you get a maculopapular rash as well, which doesn't happen for everyone though, but you can get it.
Is that for meningococcal as well, like infections or?
A maculopapular rash. Maculopapular rash is really like non-specific.
Oh.
Like once you do like derm, it just basically means like a rash that can look like anything. Yeah, so it doesn't mean a lot. But they're like different infections can be associated with rashes, which just sort of look like that. So it can get a rash. Then it tends to, after that, if you seroconvert, so not everyone seroconverts, basically meaning they might get exposed to HIV, but they don't like sort of get infected in the long term necessarily. So that's during what happens with the seroconversion. And then you have an asymptomatic phase, which can sort of last up to 10 years, where basically nothing's happening except the virus is infecting more of your cells. And then you start to get symptomatic. So it starts sort of off as just like more susceptible to infection. So just basic infections. You're more AIDS-defining illnesses, and then that's classified as AIDS. Yeah, so that's all on that, so we won't go through it. So your AIDS tends to be, AIDS is defined as either you have an AIDS-defining illness, and it tends to be at around about a CD4 count of less than 100. Yeah, and so this is just like a basic summary. Obviously, you need to know details about it for like pre-test and post-test counselling. So you can get pre-test counselling, so they're about to have a HIV test, or like you're counselling them for the HIV test to get consent.
So this is like the Western blot.
Yeah. Yeah. And then otherwise it can be post-test, so they're coming back for the results from a Western blot, say.
Yeah. So what's a Western blot? Is it the same? Is it like you get a blood test from the person where you do?
Yeah, it's just a different test for Western blot. I know it's on.
Blood film, is that it?
I don't think it's. I don't think, and maybe it is. I'm not. I can't even remember. Sorry. Yeah. I know that. Yeah. I thought it was just a blood test, but it might be. Actually, yeah. Yeah. I think we've gone through most of that anyway. In terms of management, you've got your sort of lifestyle stuff, which is your safe sex practices, not sharing needles, blood donations, stuff like that, educating people like women about the risks in pregnancy, and also as well like the fact this sort of comes under consent, but like that's a notifiable thing, and you have to do contact tracing as well for HIV. It needs monitoring, so viral load, CD4 count. You also monitor side effects of medications and ensure that they adhere to it. So, yeah, I don't think with the HIV therapy, like there's lots of info out there about exactly what they use, but I don't think you need to know every specific drug. I don't know, maybe you do, but I feel like if you know that you use combined antiretroviral therapy, and the main sort of most important group that they use is the transcriptase inhibitors, which is your NRTIS. And there's like plenty of different examples of them. That's probably what I would think is the extent, because otherwise it gets like there's a lot. Yeah. Yeah, it's a bit ridiculous. Yeah.
I mean, even know which ones were important.
Yeah.
Which ones weren't, they don't even specify.
Yeah.
They just use each one depending on the situation.
Yeah. Yeah. So from what I read about it, I think they tend to use, like the reverse transcriptase tends to always be in the group. So as I said, so they like use 3 active drugs, so 3 drugs at least, like pretty much always comes from the NRTIs, often 2. So that's probably about what I would know. And you don't actually treat everyone, not everyone gets antiretrovirals. It's sort of only if, so well, not only if, but you always commence if they're pregnant because you don't want it to transfer, you want to minimize the transfer to the fetus. If they have low CD4 counts or if they have evidence of opportunistic infections. And as I was saying before, acquired immunodeficiency syndrome is basically when it gets so low that you're becoming susceptible to infections that you usually wouldn't be susceptible to. The good thing is, like in places like Australia, where we have good treatment available to pretty much anyone who gets HIV, like most people don't get AIDS. And AIDS is essentially what kills people. And it takes like years to, like usually like at least 10 years to get from you get HIV to getting to AIDS or longer. And that's without treatment. And there's lots of different ones. These were sort of the ones that I thought you are worthwhile knowing the association to HIV. So toxoplasmosis, PJP. So do you know what toxoplasmosis usually sort of?
The cat scratch.
Yes, that's right. Yeah, and
70% of people in France have it or something.
Really? Oh, I didn't know that.
It's indolent. What's the word for it? It's like it doesn't affect.
Yeah, latent. Yeah.
But that's why toxoplasmosis comes up in people with immunodeficiency.
I think it tends to like have effects in your brain, sort of neuro.
I think so.
Yeah, effects. PJP as well. So that tends to be obviously like a pneumonia sort of picture. Mycobacterium. So that can be your Mycobacterium avium complex or TB. So like again, lots of people have latent TB and then it activates during HIV. Kaposi sarcoma. So that's a type of like cancer which is shown in the picture. It's associated with HHV8, so human herpes virus 8 as well. And in immunosuppressed people can cause this cancer. CMV, so that's like really common, but it actually causes severe illness in people with HIV. Histoplasmosis, cryptosporidium, and just even recurrent bacterial infections can count as AIDS defining if it's a child who has a known like mother who had HIV. Okay, influenza. The thing to know about influenza, like we mostly know what like it presents as. It's like the flu. So the things to sort of know are really like the 3 different types. So you've got and they're based on their core protein, so A, B, and C. And so A is the like most severe and the most common. B is like next, and then C is sort of the least severe and the least common. And you have like sort of these embedded membrane proteins, which are your hemagglutinin, so is denoted as your H, and your neuraminidase, which is denoted as the N, and they're important in sort of classifying your influenza A group. Yeah. Incubation, I've done this for all of them, intubation for all of them. Incubation is usually 2 days. So again, it's something that happens quite quickly. Yeah. And so antigenic drift and shift, that's again something to know what it is. So drift, and I think it's pretty self-explanatory with the actual names of them. Drift is like not that much of a change. And then shift is like a big change. And it normally happens in influenza A. And it's like generally sort of major changes in your H and N proteins. And that's what causes your like pandemics and epidemics and things like that. You don't normally investigate, but if you do, if they're inpatients or at high risk outbreak patients, you do a nasopharyngeal swab. Prevention is the quadrivalent annual vaccine. Worthwhile knowing it's quadrivalent, I guess. Quadrivalent, yeah, so like 4 strains. Yeah. Management, you normally don't treat, so you only treat really, like you can treat with sort of antipyretics and analgesics for anyone, but in terms of the antivirals, you don't give it to everyone, only sort of if they're complicated or high risks. and it usually should be within 48 hours of the symptom onset. So they're your neuraminidase inhibitors, which is easy to remember once you remember that the HN thing is the neuraminidase. So that makes it easy to remember that part. And it's your oseltamivir, which is your Tamiflu, and zanamivir as well. You can get complications, so you get like a secondary pneumonia, which is viral, or secondary bacterial. Secondary bacterial, I'm pretty sure, is more common post, like as in secondary to pneumonia than getting a viral pneumonia. Otitis media is especially happens in kids, and you can get Guillain-Barré as well. But do you know what classically is like the classic thing to cause Guillain-Barré? No, not influenza. Do you know the classic thing to cause Guillain-Barré? Like what it's after? It's like someone gets something. No, I don't think so. I think it's Campylobacter, so like a gastro, I think classically. And then so they classically get sort of the gastro, and then later they develop like an ascending. Yeah.
How'd you know that? I don't know, I thought it was.
Yeah, I think so. Okay, and then these words are actually worthwhile knowing as well. So endemic means that something's like constantly present, unusual presence of a disease in a particular population. So like malaria can be endemic in different nations. So it's like at the same sort of rate all the time. An outbreak is like a localized increase. So like you can have an outbreak in a school or a hospital. Epidemic is like, again, sort of like generally sort of bigger. So it's a sudden increase in a wider geographical area, sort of indicating that it's spreading sort of quickly. Pandemic is when it's crossing multiple countries or continents. So
What's USU?
USU. That's usually, sorry, that's me denoting. Sorry. Sorry, I should have taken that out. TB, okay. Has someone gone through TB in other lectures? I don't know. No, that's okay. Yeah, so Mycobacterium tuberculosis. Yeah, so it's actually like really common. So 1/3 of the world is infected, but only 10% get active disease. So that is still quite a lot. And sort of in an Australian context, they are usually immigrants who get it, sort of, or like in a question context, it's usually immigrants or someone who has known exposure to it. And again, HIV is a risk factor for it to actually become active. It's transmitted by inhalation of airborne droplets. I think it's one of those ones where it actually takes quite a while. So you have to be breathing the same air as someone who has it for quite a while. They have to have active TB for it to be able to be transmitted to you as well. So latent essentially is the TB is not multiplying, but it's in you have had the infection in the past. And it becomes positive on MAN2 or quantiferon, and active, the TB is multiplying. And you sort of need to do the acid-fast bacilli staining to diagnose it. So hemoptysis is probably the big thing to know. It can present sort of similarly to like lung cancer. I think that's probably the main thing in questions that you differentiate between is TB and lung cancer in questions. So I think that's when you start looking at risk factors, because the clinical presentation can be quite similar. So like loss of weight, hemoptysis, cough. And so your screening test, as I was saying, is your MAN2, which is the skin test, and the quantiferon. Again, these like could come up, probably unlikely, but could come up in a counselling station for like OSCE stuff, but I don't know. Quantiferon is a blood test. So the MAN2, essentially what happens is they get the sort of skin test, and then they have to come back to see whether this like wheel has grown. So, which is not as convenient, and it's just doing a straight blood test because you don't have to come back again. And I'm pretty sure the MAN2 also shows positive for anyone who's had the vaccine as well, because there is a vaccine. I've forgotten the name of it. But there's a vaccine that you can get for TB, and it shows up positive with the MAN2 as well. So you might not have latent TB, but you'll get positive if you had that in the past. The buzzword in terms of histology is caseating granulomas, which will look like that. I don't really know what that looks like, but yeah. And so you definitely need to know sort of for sputum staining, it's acid fast bacilli on a Nielsen stain. And the other sort of buzzwordy thing is your GON focuses as well. Yeah. And it's actually worthwhile knowing sort of what a chest x-ray looks like as well. So like hilar, adenopathy, effusions, and upper lobe pathology in particular, especially for primary TB. But you can also get, so that's sort of the look of it, but you can also get miliary TB, which basically means disseminated disease. Is miliary. And when that comes back to the lungs, it sort of gives that like diffuse sort of like grainy appearance. Management, you definitely do need to know that as well for this. So your RIPE acronym. Also, yeah, like if they have active pulmonary TB, they have to go in a negative pressure isolation room. So, and your RIPE is like your rifampicin, isoniazid, pyrazinamide, and FM-butol as well. And so you treat for 6 months. The first 2 months is the full lot. The next 4 months is just your rifampicin and isoniazid. Also worthwhile knowing some of the key side effects as well, because I feel like they can also come up. So rifampicin, like orange secretions, isoniazid hepatitis, also pyrazinamide hepatitis and arthralgia, and FM-butol as optic neuritis. And with latent TB, you can give like a single drug, so usually isoniazid, for about 6 to 9 months to prevent reactivation, so to just try and destroy the TB, I guess. Infective endocarditis. So Staph aureus is the most common. It's virulent, and so it presents very acutely, and it's quite severe disease. It's often sort of skin origin, and it can be a hospital-acquired infections. And so if you're suspecting hospital-acquired, you give Vanc instead of Fluvox. Yeah. Strep viridans is also possible. So that one's less virulent, gives a sort of subacute presentation, and like might be associated with like mouth work, because that's where it sort of lives. Enterococci can also cause it, tends to have a bowel origin. Your Hakek are these other gram-negative organisms which don't often cause it. And you can also get coagulase negative staph. So that's like Staph epidermidis. Flora, but can sort of affect prosthetic valves as well. The valve that's most common is mitral. Second most commonly affected is aortic. And if they have IV drug use, tricuspid is classically the most one as well. So you suspect it with a new onset murmur and a fever is basically the two things that you're looking for. The other sort of really ones to look for are your splinter hemorrhages, your Osler's nodes, and your Janeway lesions. Do you know which ones of your Osler's nodes are versus Janeway lesions? Yeah, Osler's are painful. Yeah, that's the main thing. And Ross spots, do you know what they are?
I know it's a key word.
Yeah, so it's like, occurs like in your eye, and I think they're like, pretty sure retinal hemorrhages in your eye. Yeah.
Is it? Actually, I feel like I know you.
Really?
Like, I mean, is it common? Some people have like some.
It's probably like a different thing.
Yeah, maybe.
But yeah, maybe it looks like it though. Yeah. And the key sort of risk factors are if they have like a structurally abnormal heart. So like they've had congenital heart disease or rheumatic heart disease, or they have prosthetic valves, main things. Also bicuspid aortic valves, and then if they're IV drug use as well. Yeah, and that's what, there we go, that's what your rough spots look like. So being a retinal hemorrhage, that sort of, I'm pretty sure you can't see it like unless you actually look in the eye.
Yeah.
Yeah. Duke's criteria, also worth knowing. So your major criteria are positive blood cultures with your typical organisms, or a positive echo. Then you have other minor factors as well. So if they have predisposing risk factors, they have a fever, evidence of sort of the other features. So like your splint hemorrhages and your Janeway lesions and your Ross spots and stuff like that, which are classically IE related, if you have a positive blood culture with other organisms. So yeah, you definitely need to remember to do blood cultures and echo. Yeah, and your empirical antibiotics, which is also worth knowing, is benpen, fluclox, and gentamicin. And as I was saying, so if you think it could be hospital acquired, instead of, I think that should be, I'm pretty sure that should be fluclox instead, not benpen. Should be switching that bank for fluclox, I think. Yeah. Maybe just check that. I don't know whether I've written it wrong, but that's actually how it's meant to be. And you treat them for 6 weeks. And you can do surgery if they fail antibiotics or it's a very large vegetation. And the complications to know are emboli, so which can give you strokes, or can also give you sort of PEs as well, and heart failure. Okay, cellulitis and necrotizing fasciitis as well. I haven't done much on that because I feel like they're pretty self-explanatory as well. So cellulitis is your deeper dermis and subcut tissue. It tends to be beta hemolytic strep and Staph aureus. Risk factors are sort of venous insufficiency, so if the flow through the legs is sort of not as good. They're like red hot, swollen, tender, and usually unilateral as well. And there might be history of like a skin break or an insect bite, and you treat with fluclox. Because you're trying to cover staph is the main thing you're covering. Necrotizing fasciitis is rapidly progressive of the deep fascia, and you get sort of necrosis of the subcut tissue. And it's usually sort of strep pyogenes, or this is group A beta hemolytic strep. So you can remember like gas, so GAS is like how it's often denoted, group A strep, and this sort of causes gas bubbles like under the skin as well on palpation, so like a crepitus sort of thing. It's like very, very painful. So it's one of those things I think like can be denoted as like pain out of proportion to like what you expect. So yeah. And you have to have really aggressive treatment. So they do like radical debridement and can even use amputation and like really strong antibiotics. So like meropenem, vancomycin, and clindamycin as well, because it can be fatal. So. Other things, so I've got specifically about your dengue. So good to know that this is viral as well, because sometimes they can put in questions like a viral mosquito infection, and they're referring to dengue, not malaria, because malaria is parasitic. So sometimes they don't give you the names, they just give you a description of what it is. So also the first time you get exposed to dengue, it's benign. The subsequent ones after that are symptomatic, and they have increasing risk the more you're exposed to it. So when it is symptomatic, it's sort of sudden onset fever. It's a blanching rash. So you get this classic islands of white and a sea of red, and it's supposed to look like that. They can get back pain. The other thing it can be called is like back break fever, I think, because that's like about the back pain and the fever. If you get the hemorrhagic part, you get vascular leakage, so effusions and ascites, thrombocytopenia, so bleeding and bruising, and leukopenia as well. You diagnose it by serology, and sort of in terms of management, you admit them, you give them fluid rehydration, and then sort of symptomatic relief, so Panadol and antipyretics. Malaria, in contrast, is parasitic. So your main one is falciparum. The other ones, there's 5 different types, but I don't think you need to know all of them. You need to know falciparum is the main one, causes the most severe disease, and it's the most common. The other ones to know are the vivax and ovale, which are the only 2 that have V's in them, can survive in the liver. So they're the ones that can like survive for dormant, it can be dormant and reactivate. So there's like when you can get it years after you've been exposed to, well not years, but like a year after you've been exposed to the malaria itself. It has a flu-like prodrome, classically has high spike hemocyclic fevers, gives you hepatosplenomegaly, and you can get thrombocytopenia. You need to remember to do thick and thin films. Do you know what the different, like which ones are the thick is looking for versus the thin?
It's to see if there is organisms, then it's to see what kind of organisms.
Yeah, that's right. Yeah. And you need to do, if you're suspecting malaria, you need to have 3 negative spaced out to exclude whether they have malaria. Rapid diagnostic testing for the malaria antigen, but that's only for falciparum. So, yeah. Instead of prevention stuff, also obviously your lifestyle things, so like repellents, and people are traveling, so travel advice, so long clothing stuff. Doxycycline is one that definitely is worthwhile knowing. You need to take it 2 days before you leave and for 4 weeks afterwards. There's also mefloquine, I don't know how to say these things, and then atorvaquone and proguanil. Those last ones can be used as treatment as well. And I guess, to know that if they've had that as their prophylaxis, you don't treat them with it later on. So if they've been with the atorvaquone proguanil, if they've been treated with that, you don't. Yeah. If they've been given that for prophylaxis, you don't use that for treatment. And then for treatment, again, there's like a lot of different types. But there's sort of artemisinin-based combination therapy. And you can give, if it's Vivax or Ovali, you can give primaquine. So that will specifically be able to target the liver stuff, the dormant stuff which remains in the liver. You have to rule out G6PD first because it can trigger hemolysis. Filariasis. So I just remember this as filled with fluid, so I'd always forget what this actually was. And it's basically just like the lymphedema stuff. So it's caused by roundworms, and it inhabits the lymphatics, and so you get lymphadenitis and lymphadenopathy. I don't think there's much more you need to know about it. Can cause river blindness. Yeah. I guess. And then shingles comes up like so much. So it's reactivated varicella zoster virus. Tends to happen more in old age or in people who are immunocompromised, vesicular and dermatomal, and it's pretty much most of the things you can work out from there. In terms of treatment, you treat it if the rash has been there for less than 72 hours. You can give famciclovir, valacyclovir, or acyclovir. The problem with the acyclovir is you have to take it 5 times a day, which is annoying. So generally, the other ones are better. There's also a herpes zoster vaccine for over 60s as well, which can help prevent it. It doesn't fully prevent it, but can reduce the chances of getting it. And people can get post-herpetic neuralgia, which is basically the rash is gone, the infection's gone essentially, but they've got pain in that dermal tonal distribution, which is really quite hard to treat. You can also get it affecting your eyes as well. And then this is just literally the animal-related infections, so you can like refer to it. So Q fever tends to be cows. And pitysicosis is birds. So I just think of pits as being like the seeds, and so I think of birds. Lissa virus is just because like the Australian bat Lissa virus. So that's easy. Bartonella is the cat scratch disease. Oh, that's toxo as well. You've said toxo, but I think Bartonella is the classic. But toxo can come from cats as well. Leptospirosis, got a whole heap of things. High-data diseases from cows, sheep, and dogs, and hendrovirus, horses, and bats as well. But again, like if you want to learn more about them, look at the CDC website because it has like good information. Okay, do you want to go through MQs? I've got quite a few. Yeah, so you can just take it in turns, or you can start.
For each of the following scenarios of chest pains, the most likely diagnosis. 38-year-old female presents complaining of tingling and sometimes scalding pain across her chest from the central trunk, descending across beneath the right breast under the right arm. Pain is associated with a red, blistery, itchy rash and a general feeling of malaise. So she has shingles.
Yes. So that's classic and fairly straightforward, I think. And with this one, sorry, It's your turn. Can you try and answer it, and then also tell me what you think what your differential actually is for it?
What favorite breath was that? Sounds like I'm going to do a chest X, right?
Yes. 4. Do you know what? Yeah, in a 19-year-old university student, do you know what what would you be like? What type of pneumonia might you be suspecting? Do you know? That's like trickier part of the question, but
Is it going to be a weird one?
it's not that weird, but not like the most classic.
Oh, you might do PJP because
No, they don't have. No. I was thinking more like mycoplasma, because mycoplasma I think is associated with and it's associated with like younger adults, especially those in like college dormitories or something like that. Yeah. So I think, but isn't necessarily. You don't need to know that to answer that question. You just need to think pneumonia, and then do a chest X-ray. But yeah. Next one.
Yes, sir. So from the following patients, please select the most appropriate answers. 60-year-old alcoholic man is brought in with respiratory stress. Chest X-ray demonstrates low bowel consolidation in the right lower lung, which of the following is the most likely positive organism. So is an alcoholic, therefore Klebsiella.
Yes. So it is.
And also it's low lung, so it's not TB.
Yeah. So the other thing to know though that I found out is that alcoholic, so it is Klebsiella for this question, but strep pneumoniae, so that's the most common cause of pneumonia. It's also, there's increased risk of getting that if you're an alcoholic. And then so if they're both in the question, I think it's actually strep pneumoniae. But luckily for this one, it's not in the question.
Oh
I feel like it would be unlucky.
That's so
Yeah,
mean.
but
it teaches all about these buzzwords, and
Yeah.
the buzzword's going to bite you in the
I
ass.
think I think it probably won't happen, but that is, but in this case it is Klebsiella from my understanding.
It's fine, half people get it wrong.
Yeah. Also with all these questions, like obviously these are my answers of them, so they, could be wrong, but yeah. So what have we got? Yeah. So this one's 24-year-old, upper respiratory tract infection, then had palpitations and dyspnea, signs of cardiac failure, then completely recovered over several weeks of conservative management. What do you think they had? So we didn't really go through this, but still.
Does he have a viral malpractice?
Yeah. What made you think that?
Because, it's a post-viral infection, yeah.
Yeah, cool.
And it's not painful. It would be painful if it's
Pericarditis. Yeah, so that's probably the main thing. And it's also self-resolving.
Pericarditis sounds like, wait a minute, it doesn't have chest pain.
Yeah, I'm pretty sure the first time I did this, I said pericarditis and then realized, looked it up, and it's not. And it's self-resolving as well, like pericarditis. Usually you need treatment.
This below was probably not the reason. 22-year-old woman presents with fever, sore throat, enlarged cervical lymph nodes, and enlarged spleen. So I want to say EBV, but does it present with enlarged spleen? I guess it does it?
I think so. I put EBV, yeah. So.
She has a favorite rival in the hospital in May. Is that?
Yes. Cool.
29-year-old male, it's an ED, 12-hour history of increasing headache and next physical allergies, agitated, high temperature, photophobia, positive current sensor. Is that the neck thing?
Yeah, so I think when they
it's just
then,
neck stiffness, isn't it?
Yeah, so I think it's like when they, flex the hip and then they get pain in their neck. Yeah. Pretty sure.
Okay. Yeah. So this means he's got neck stiffness, right?
Yeah, so that's all it means, yeah.
You also know he has a perfect rash on his hands and feet.
Yes. Cool.
This year now. Long abdominal pain.
Yes.
Oh, I see. That makes sense. 7-year-old acutely red and hot left leg below the knee, similar episodes in the past, response to antibiotics. Febrile, diffusely inflamed superficial abscess or in arm. So you would treat him with fluvox.
Yeah.
Oh, I see. Cheesy.
Yeah, that's cheesy.
KC80 granulomas.
No.
That's kind oh.
It's not.
Oh.
Really?
Because she had antibiotics for
Yeah, it's not CD.
No, it's not. It's
That's GI.
Yeah.
no. So this one's like candidiasis.
Who's the hard ones?
No. No.
Candida infection would be
Clotrimazole is for candidiasis. I think,
close guess. Yeah, I would guess it.
yeah, it's either one of them. And I feel like you're not really taught it, but it's on the faculty released one for your year. So
So what's ketoconazole used for?
So yeah, why?
ketoconazole is used
So
for
if you have a vaginal discharge, that just leads you to
no. I think it's like the cheesy looking is candidiasis, because you can get that sort of in your throat as well, that sort of white stuff, and it's candidiasis. And for candidiasis, at least vulvovaginal, it's clotrimazole. Ketoconazole, I don't actually know what you use for.
My notes it says fluconazole.
Fluconazole.
No idea. I'll just write that because that's from the exam.
Yeah, I think it says it on ETG as well. I'm pretty sure, but there could be like two different drugs they use.
So then what's fluconazole used for?
It will also
You
be
mean ketoconazole? Oh.
No, it's not on there, but it's just the only one.
Not sure. Sorry.
Metronidazole also antifungal. Yeah, that's why it's got its name.
Yeah.
Interesting.
Metronidazole. That's like metro. That's usually for anaerobes. Yeah.
But it's also an antifungal. That's why it's got the
Yeah, Zol in
that's
it,
how I
yeah.
was like reading it. I was like, oh, that explains so much.
Yeah. Yeah. Okay.
For each, yeah, cool. 35-year-old woman presents with a level of pneumonia, status that follows. Respiratory rate is like normal, high-ish. O2 stats, oh, it's alright. I don't know what's in
Don't even look at them. You don't need to.
Yeah. Pulse. Investigations with CRP is high. What's that? That's high. Organ function. She has a no known allergies. Most likely positive. Oh. Isn't it just strep?
Yeah. So you really didn't have to.
This was a waste.
Yeah, I know. Look at it, but that's fine.
It's just the most common.
Yeah.
No clues we need.
One's a hard one.
Very fun.
I think this is the hardest one. So.
Very fun. So therefore.
Yeah. So which
Just
one?
go straight
Yeah,
for it.
actually,
Don't
like,
even
what
read
would
the
you
rest
have
of it.
gone for straight away without reading the rest of it?
Yeah, it's not.
Oh, okay. Yeah, fair enough.
Q fever. OCI, yeah, it's not there. What shame.
Starts well, and diarrhea, which means that
Unboiled drinks milk, no cows. Oh, that's fine. Bird droppings. Rainfall. So bird, city guy. No, it's not there. Probably just, well, there's no mention of chicken.
Pardon?
No, no mention of chicken.
No.
It's probably Shigella.
No. What did you say?
Campylobacter.
Yeah. So it is.
How do you
Well,
get
I
that?
believe Campylobacter. Yeah, it was.
because it's bloody diarrhea.
Yes.
But Shigella is also bloody diarrhea.
Yeah. So with this one, it's more like
It's the most common.
And it's best.
yeah, exactly.
Birds.
The birds. Yeah. Yeah. Campylobacter is like birds, or like it can be like chicken, but that's because chicken is a bird. It's uncooked
True.
chicken. Yeah. Or poultry and stuff like that. It can also be in unpasteurized milk as well. So that's another thing it can be associated with. And it happens after, and it gives you the bloody diarrhea as well. I think that's the main things are in the question, which made you get it. But I think it's very hard to get that.
I imagine it's in half the color of the buttons, right?
Yeah, I would have thought so. I don't know, but
Who's salmonella?
yeah.
Because that's where the smell goes.
Yeah, salmonella is.
So how do you, why is it not that?
Salmonella is more just chicken. It's
Yeah.
chicken like bread and other breads. I don't know.
Yeah.
Yeah.
Bacterial was chicken as well.
No, Campylobacter is definitely,
All birds.
yeah, and can be like for where birds are sort of grazing or birds are, yeah, and like water associated with that. Salmonella, I just think of, yeah, as like eating chicken, but I don't know specifically whether it can be through birds as well.
36-year-old food poisoning, 24 hours after receiving chicken, nausea, abdominal pain, still swallowing, bonus, okay. 24 hours and chicken.
Yeah, so
So you get no blood, so salmonella. Wellness of the health. Where's your, no, it's not there.
no.
Campylobacter is 3 to 5 days.
Yeah, it tends to be a bit longer. Yeah. For sure?
Is it, it's salmonella, right?
Yeah, yeah, I think it's
Oh, okay.
salmonella.
Sorry, because when I said salmonella the first time, you guys were like, nah. I was like, what?
No. I just don't know whether, yeah. They all sound really similar, so I wasn't sure what you'd actually said.
sorry.
Yeah, and so the main thing I would have been tossing up with this one is actually staph. For
Because
me,
of the acute
personally.
setting.
Well, no, not because it's acute, because I think can be associated with chicken and it's fairly acute, but yeah,
Okay.
it's not as tends to be. It would normally have manifested before 24 hours. Yeah.
So, yeah, because you said staph's acute.
Yeah, like really acute.
Yes,
Like tends to be
30 minutes to
to
6
6
hours.
hours, sort of.
Yeah.
Yeah,
Okay.
yeah.
Because it's like
Sort of.
preformed toxins.
Yeah. Okay.
She's India. Oh, yo, India though. I don't think it may not be important.
So then you should go on estimated.
Ah,
Yeah, so which one is it? It's like, what's the difference between them? The main sort of.
wait, trypanocytes is. I thought Shigella's not.
Shigella parasite, right? No, it's
No.
not.
Oh, yeah, that's
So
what I said,
bacteria.
Shigella. I was
Yeah.
like, what?
Yeah. So yeah.
So why is it not Giardia?
So this is mainly the blood. I think bloody diarrhea.
Okay.
So,
okay.
yeah.
Giardia is not.
I don't think tends to be bloody from my understanding. Yeah. This one.
For the following information. So you drill opposite time, history of IBD with alcohol abuse. Picture optical tendon pitch. Diagnosis of well, yeah, I've been doing this for about hey. Oh, true, have this.
Yeah.
Oh, true.
Yeah.
Oh, that's embarrassing. Yeah,
That's
sorry.
No, that's fine.
Yeah.
That one's. Yeah. Cool. I think this is the last one. Fuck. Don't know.
Most likely.
Yeah, it's just a UTI. Often they can give a lot of information for something which is
That's
really
what you see,
straightforward.
yeah. She doesn't have flank pain, and she has super pain. So.
Oh, sorry, I lied. There's another one.
Just getting worse.
I don't know.
Program. What is it?
Oh yeah, that's the class. That's why the answer. So I put that. Yeah. So there's one type of pneumonia which, like, classically will be also associated with diarrhea. So if you see pneumonia plus diarrhea, you think of a certain type. Which again is hard because it's not even on the list, and you have to know what it looks like, which is like really hard. This isn't one, but that's fine. We can just go through it. So it's Legionella. Can cause also diarrhea, and it's a gram-negative rod. I don't know, it would be really hard to know that, so yeah. Yep.
It's a gram negative rod. You even need to know the shape.
Yes, so yeah, and we should.
Essential was, oh yeah, simple question.
Cool. Awesome. And then I won't go through them, but there's some buzzwords. There's so many though. So that's Legionella. Yeah, I did that. There you go. So that will be there. And then just some key management. And then we've got derm. So I think we can go through derm really quickly. I think you just tell me what you actually want to know, because derm doesn't come up very. Do you guys have a path exam this year as well?
Yeah.
Yeah. So I don't think derm comes up very much on your, at least it didn't for us, like on the major written exam. It will mainly be on path. And then to study path, it's mainly just go through like the, yeah, and what they give you, like the online lecture quizzes, and like know all the different differentials. So even if it's not the answer to that specific question, know about whatever they give you, and like learn what they write in that information, because that's what they want you to know. So that's what I would recommend. Like, and it's probably unlikely to come up in OSCEs, but it could. So yeah.
And if you learn the stuff from path, you should be relatively okay to answer maybe some questions on this, maybe. Because
for
path
derm?
sometimes gives you like the background as well.
Yeah,
So
like
I'm just feeling that if I study derm path, maybe that will be enough for the actual.
Yeah, I wouldn't study it for the actual exam.
Just know, like we have some lectures on derm.
Yeah.
I'm sure if there was a question, it would just be like, no wrong.
Yeah. So I think, again, know the terminology. Phase of the skin, we don't have to go through that. Just like stop me with what you actually want to go through. Describing lesions. I really
think it's important.
Okay, I think describing lesions is like probably unlikely to come up, but it could come up. So yeah, so you, like A, B, C, D, E is the main things, and this is sort of like typically like to determine malignancy or melanoma. So asymmetrical is the A, border. So if it's regular versus irregular, more likely to be a malignant. Color. So if it's constant, more likely to be benign. If it's varied, more likely to be malignant. It could, but I don't know whether. I don't know. I can't tell you. I don't know how likely it would be. Yeah. Yeah. And diameter, if it's more than 6 millimeters, it's more worrying. You also note whether it has elevation as well. Then the other sort of things you can look at, sort of if you're describing something, is how firm it is and if it's growing sort of or enlarging over time, which is the other way it can be E. Like I've seen them written as both, as elevation or enlarging. So yeah. Conditions, so that's different ones. Benign. So you got compound nevus, which is basically just your normal moles, whereas your dysplastic nevi are the atypical moles, and then the dysplastic are associated with increased risk of melanoma, whereas like your compound ones aren't really. And then so they have the irregular shape and color. Blue nevi, in terms of histology, there's all the Ds, so they're dermal in origin. It's deeply, highly dendritic, and they're darkly pigmented, and there's no junctional involvement. So junctional meaning is like the part between the dermis and epidermis. Yeah. Yeah. Strawberry nevi are sort of a type of sort of birthmark. So they're hemangioma, and they occur in kids. So like kids are sort of born with them, and it's something that they tend to be like the red, about the proliferation of the endothelial lining of the blood vessels, and they sort of grow and then diminish over time. Giant hairy nevi are also congenital, and they're associated with like a large, if they have the giant hairy ones, a big increased risk in melanoma, and so they generally need to be removed. Yeah, and they're basically, the name describes what they're like. You can also just get congenital nevi as well, which are just like congenital moles essentially. So you're like born with that, and they're still birthmarks essentially, just like what you think of. So in terms of, this is a sort of type of birthmark, is your strawberry nevi, and that's about your vessels, and so they're red and they grow and diminish, whereas your congenital nevi, if they're called congenital nevi, they are just like sort of a patch of sort of, tends to be like one colour, and they don't grow or change over time. Bowen's disease is squamous cell carcinoma in situ, and they usually don't progress to an invasive form, but they can. Yeah, I think that's probably fine with that. Separate keratosis, has a typical like stuck-on waxy appearance. They're not related to the sun as opposed to the solar keratosis. It tends to be like in older people, and if you have a family history, increased risk as well.
Sorry, which ones are the solar keratosis in that photo?
So the one under the seborrheic is the seborrheic, the one in the solar keratosis. So that's like all solar keratosis, pretty much, like all that dry stuff.
All
those little lesions.
So it's not really spots then, it's just.
No, they can like look, if someone, you look at, so you get exposed to like so much more of this in, it's so much more just buzzwordy at this stage, but like when you go to GP, you see a lot of it, and it's just like scaly skin on like an old person's face. That's sort of what it looks like.
Old people. Like on the
Yeah.
kids, yeah.
Yeah, no, it is a lot.
Yeah.
Yeah. And it's, really rough sandpaper, like scaly stuff. Tends to be, so all your risk factors for sort of melanoma or sun damage, so your fair skin stuff, increased sun exposure are for the solar keratosis, and they're pre-malignant because they can transform into squamous cell as well. Your malignant lesions, so your basal cell carcinoma is the most common, but the least invasive, so the least bad. And you can think B for the most benign out of the three cancerous ones. And it arises from your basal keratinocytes. They have the classic description is pearly. They're usually on the head and neck. The other thing to know is the telangiectasia, and they can ulcerate as well. You have a couple of different types. I don't know how important that is. Diagnosed by biopsy, excision is the gold standard for it, but you can, with basal cell, use cryotherapy, which is burning it off with the liquid nitrogen, or like the topical sort of cream, so 5-FU or imiquimod. Imiquimod, that's how you say. And that's sort of like a classic difference between the squamous cell and the basal cell. So your basal cell is more pearly, your squamous is more sort of ulcerated and sort of angry looking, I guess. But sometimes that can be hard to distinguish between. Squamous cell is second most common, and it's more aggressive than BCC, but less aggressive than melanoma. So it can metastasize, but it's unlikely to. So it's usually fairly good prognosis, but can be locally quite invasive. Again, sun exposure, fair skin can be associated with HPV 16 and 18. This is proliferation of the squamous keratinocytes versus the other one was basal. The main thing in terms of distinguishing these on questions is that they're tender, whereas the basal cells classically aren't. They're scaly, have heaped up edges, and they might indurate. They have more rapid growth compared to a BCC. Have a couple of different types. So your Bowen's, we've already gone through it, so it's in situ. These are your kerato. Think of the word sounds like crater, so they sort of look like a crater. And these ones, they sort of have a rapid evolution, but they can resolve spontaneously. And then also Marjolin's ulcer. I don't think that comes up as much, but it can, that's sort of where it arises from chronic wounds and scars. This one you can't use cryotherapy, so this one sort of needs excision all the time. Although most of BCC you excise anyway. Is obviously the most dangerous, poorest prognosis. All the classic sort of risk factors, histology, it's of your melanocytes, so it's different to the other ones. Both the other ones were keratinocytes. So these are both melanocytes. And they also more likely to do vertical, which is pagetoid spread. Then your things you're looking for are the asymmetry, the irregular borders, various colors. So you can see that in the picture, it has various colors in it, and it's rapidly changing. it is actually worthwhile knowing. I don't know. Yeah, you probably looked at it on the on the path stuff, but you do need to actually know the different types. So superficial spreading is the most common, and as it sort of the name says, it sort of spreads superficially first before it goes down. So it means it has a better prognosis compared to something like nodular, which is sort of less common, but it vertically spreads early. So it means that if it spreads early vertically, it goes deeper earlier, and therefore spreads, it metastasizes earlier. And they can be amelanotic, which means they don't have colour, which is even harder for them to be picked up. Maligna is an in situ version of a melanoma, so it's confined to the epidermis. So not actually malignant at that stage, but when it becomes lentigo melanoma is when it then invades into the dermis. Your acral lentiginous is on your soles and palms, and it's in darker skinned populations, and it's the least common cause as well. So for diagnosis, you generally do an excisional biopsy. So if you're suspecting a melanoma, you just want to get most of it out straight away. And you also want to make sure, I think it's about making sure you've got all of the tissue to sample. The two different types of staging, which again you should know as well. So Breslow thickness is when you actually measure the thickness in millimeters. Clark's is when you measure, it's about what level of the skin the lesion has invaded. So if it's just in the epidermis, if it's in the dermis, or if it's gone into the subcut tissue. Management, so you've done the biopsy, so you do an excisional biopsy, and when it's diagnosed, you do a wide local excision, so you do more excision later on, and you do it based on these sort of numbers. So if it's only 1 millimeter sort of in depth or thickness, you do 1 centimeter margin, and it increases. So if it's over 4 millimeters, you do a more than 2 centimeter margin. Needs regular follow-up, and then depending on whether there's any evidence of spread, you also do chemo, radio, immunotherapy. Skin lumps. So these ones, I don't know if you actually want to go through these. Like they can come up on derm questions. Do you want to go through them or not?
Maybe very
briefly.
What do you call that? The fuzzy parts.
Okay. Lipoma. The buzzword parts is probably it's fluctual. So you can move it, so it moves. That's probably the main. Yeah. So it can move. That's probably the main thing. The fibroma. The probably things for this one is that, but they're button-like, and the dimple sign basically, because they're tethered. So if it's a fibroma, it's like tethered. It's a dimple sign. So basically, when you compress it from the sides, it like dimples in the middle. So they're probably the main things to know. The thing to know is that it happens generally in kids, and it tends to be on the lateral third of the eyelid. So if anyone has that sort of lesion, it's going to be a dermoid cyst.
It's just really common, right? Like I remember when I was in gen surg rotation, like we saw like 2 of those.
Oh, really?
Yeah.
Yeah, they probably are. I actually don't think I've ever seen one, but they probably are common. Yeah.
And it's actually like what a big dermoid cyst.
Yeah.
It's
So.
not actually sebaceous.
Yeah. So you can have 2 different types. So your epidermal does contain sebum. So that one is actually sebaceous. Then you can also have hyla, which like sort of originate from the hair follicles, which contain keratin. So it depends what type it is. And they can have a central punctum, and they can get infected as well. And like often, I think classically, I feel like on the scalp, I feel like that came up on the scalp. Yeah. Rashes, eczema. What you want to know about eczema is it's really itchy. Tends to present in kids mostly. Eosinophils, when you sort of, there's something like in the, will be like very present. And then it has this sort of, it's more watercolor in color. It's not well defined, and it can weep as well, and tends to be flexes. So in the flexes. Whereas this is compared to psoriasis, which tends to be not itchy or less itchy, and it's on the extensors, so like the outside. And it's better defined. So there's sort of the 2 things you need to be able to distinguish between. You probably need to know the different types as well. So atopic is kids mainly. Contact irritant is not immune mediated, so that's just occupational exposure, like overexposure. And it's contact allergic, they actually have an allergy to it, which worsens every time you're exposed to it. So stuff like nickel, rubber, latex, head eyes. get infected, so you can get eczema herpeticum, which is when it's infected by HSV, and you can get sort of impetigo on top of the eczema, which is usually Staph aureus. Seborrheic dermatitis classically is like scalp. It's caused by a type of yeast. Pomphilox is when it's blistering. Discoid is coin-shaped, often in adolescents, and varicose happens when they have venous insufficiency. Psoriasis is autoimmune. Hyperkeratosis is the main thing, so they're having massive turnover of the keratin layers, so it gets like very scaly. The main things, you can get the nail changes. You get plaque, which is the classic pustula, which is sort of gross, and it's on the hands and feet, and they get pus, and it's quite painful. Gutate, I don't know how to say it, tends to be adolescents post like a strep infection to have a good prognosis, and tends to like have this raindrop-like appearance. Ulcers, pardon?
I heard these are important.
Yeah, so these can come up. So you need to be able to distinguish between them. So venous, arterial versus neuropathic. So venous tends to be irregular in shape. They tend to be painless. They can be painful, but it's more like compared to arterial, they're less painful. And it's usually on the lower third of the leg. Arterial, regular, have like a punched out appearance, usually below the ankles, and they're painful. Heal poorly because you're not getting good blood supply. Neuropathic, key thing is they're painless because your nerves aren't working. Usually good healing, but if the arterial and venous supply is fine, they're good healing because they've got good blood supply. And it tends to be sort of like on pressure points. If it's diabetic, it can be sort of neuropathic or ischemic, so ischemic being arterial. So if you kind of present with a combo of the two of them. Yeah. They're probably the main things. Pressure sores. So, yeah. So it's just due to pressure. The staging is basically whether it's the skin still intact, whereas there's some skin loss, whereas if it's full thickness skin loss, and then whether it's full tissue loss. So right down to like the muscle and bone, which is gross. So that's just about keeping people clean and using good mattresses and stuff in hospital and making sure they don't lie in the same position for ages. Yeah, I think I think so. I don't know. I don't think, hopefully it doesn't happen as much anymore, but I think in the past when there wasn't as much sort of protocol about it. Okay, and there's only 4 of these, so we can go through them really quickly. This one's hard, I think.
Was an intra-epidermal blister. No diagnosis could be reached because the suitable test was not offered. Some of this I would say yeah, I have no idea. Probably just pathology as a guess.
So I think this one is immunofluorescence. So this one, the hard thing is like to know what intraepidermal blisters, and then so according to Dermnets, because that's what I looked up for these, was intraepidermal ones are sort of your HSV, chickenpox, it can be eczema, or it can be pemphigus. So pemphigus is rare, and I don't actually know that much about it. So immunofluorescence is I know that for both bullous pemphigoid and pemphigus, the way you diagnose them is through immunofluorescence. The thing with bullous pemphigoid, it tends to be, I think that's more like subepidermal than intraepidermal. But again, this one's, I don't know, hard. And apart from some stuff for derm buzzword, like pathology, it's not that important. Yeah. These ones are more straightforward.
In situ superficial superficial spreading melanoma?
So you've said that basically because it's extending
Still
along.
on the basal layer.
And it hasn't gone. Yeah, cool.
So then what's my target?
Maligna. So
It's just sun,
it's-
right? Sunspots? Is that
yeah,
what
sort of, but it can become.
melanoma?
Yeah, so it is actually melanocytes.
Yeah.
But I think in this case, I think just because superficial spreading is more common, I think
Yeah.
I would have said this one. But it could be, that would be the other option there that could be possible. Yeah. Because it's in situ as well.
That was the next question.
Yeah, they're similar.
That's ridiculous. So that means it's spreading around. So it would be 4 melanoma.
Yeah, that's right. So that's your Clark levels. Yeah. It's good because I didn't give you like level 5 and level 3 as well, so you didn't have to know.
Yeah, that was the only reason. It was the only one. It wasn't meant so.
Yeah. Nice, easy. Okay, and then that's the stuff. I didn't cover everything, but yeah, most things.
Nice. So, thank you so much. That was pretty helpful.
Okay.
Thank you.
Thanks for coming.
I was actually really surprised. I thought this would be really useful because ID is like, I thought everyone would do badly in ID. Maybe it's just me. I hate ID because like all their like treatments and all that, it's like
That's okay. That's good. Go ahead.
horrible. Like the treatments for ID, like for example, you learn this from Toronto, you learn that from your notes, but you actually have to go to ETG to find the real.
Yeah.
That's a bit annoying. Yeah, antibiotics and stuff. Really tricky.
I think once you like learn the principles of it, it's not as difficult.
Yeah.
Yeah.
And